I've been invited to talk about understanding corneal topography. So basically, corneal topography is an instrument or is a report which a lot of people are confused about. So what do those colors mean? What do those numbers mean? Why the numbers are positive? Why some of the values are negative? So, there is a lot of loopholes amongst optometrists and yeah, even with some of the ophthalmologists. So we are over here to breach those loopholes and then, try to understand that how corneal topography work, you know, and what do those reports mean? What do those colors mean? And so on. Right. So after today's session, I hope most of us can go back with the take-home message and would be able to diagnose some things on the topography report. And if someone is already using the machine, so I hope it enhances your knowledge. And if any one of you knows better than me at the end of the session, please share it with us. Share the knowledge with us. It's a good learning activity for all of us, including myself. Right, so let's start with the session. So, corneal topography. So basically, we'll be focused on the cornea, definitely. So we'll be focusing on two main factors about the cornea. Number one is that the cornea is an aspheric surface, and the number two is that it is, responsible for most of the refraction occurring in the eye. We won't be getting into much of details about the corneal layers and stuff. And secondly would be the precorneal tear film. So when we talk about topography, so the tear film plays an extremely important role. Why it plays an important role, we'll come to that throughout the slides. But yes, it is important because it is always bathing the cornea. So astigmatism, right? So there are two things that we can measure about the cornea. Number one is the refractive analysis. Refractive analysis is means how does the light refract through the cornea. I think the slide is stuck. Now can you see the slide? I hope everyone can see the slide of astigmatism. Can somebody please give a confirmation?
Yes, it's
Yes,
okay.
yes, sir. It's
You
visible.
have
Yes, sir.
All right, great. So astigmatism. So astigmatism is it is the refractive aspect of the cornea. So it is basically about how the light is refracted by the cornea, right? So our friends very beautifully explained that. Am I audible now? Sorry.
Yes, sir. Yes, sir. It's
So
audible, sir. Yes.
yes,
Yes,
I'm
yes.
really sorry for the interruption. So astigmatism, basically, our friends really very nicely, mentioned the types of astigmatism. They could be regular astigmatism, they could be irregular astigmatism. There could be with the rule, against the rule, oblique astigmatism, and there could be astigmatism, which could be anterior surface of the cornea or from the posterior surface of the cornea. And lastly, the astigmatism is something known as an lenticular astigmatism and something known as corneal astigmatism. So when we talk about the topography, in topography we basically talk about the anterior surface astigmatism, the astigmatism arising from the anterior surface of the cornea. So that is the refractive part of the cornea. Second is the geometric aspect of the cornea. So geometric, what does the geometric aspect mean? Geometric aspect means that how much cornea is refracted by the cornea. Hello, Kapil.
Yes, sir. Yes, sir.
Kapil,
Sir,
is it possible to change the application instead of go to meeting? Can we use some other app?
no, sir. Sir, we might be crossed more than 100, and we have not feasible to collect the more than hundreds in June. So I guess it will be a better, sir. Can you please try one code? I'll be sending you by the message, and if you try this dial to this message, and nobody will be called to you. This was the basically for engaging to the other people. I said you can do the sir. Am I audible to you? You can also use the not disturb mode, sir, in your phone. Hello, sir. Are you there, sir? Hello, Harshal, sir. Are you there? Harshal, sir. I guess. Okay. Can you please wait? We are so sorry for this type of disturbance. We never experienced such a form. Please hold on for a minute. I guess we can wait, right? It's technical thing we can predict. Yeah. Okay. Is it come? I don't know. After hello, sir. Are you there, sir? Okay, sir.
Hello? Hello, am I audible?
Yes, sir, you are, sir. So I'm
All
making
right.
once again. Okay. So I
Mm-hmm.
guess you have problem with your internet. So we have having a such problem.
Yeah, I think so. It's my internet. I'm really sorry. It's irritating right now. Let's not waste any more time and let's get back to it.
Okay.
So if I can just share the screen, so let's go on with it.
Okay. Yes.
Thank you very much. Just please confirm if my slide is visible.
Okay, sir. Let me check. Yes, sir. Now it's visible, sir.
All right, very good, very good. Okay, so basically, I was telling you about the corneal refractive analysis. I told you about the refractive analysis. So it basically tells us about the astigmatism, and there is something known as geometrical analysis. Now, in geometrical analysis, it basically tells us that how high or how low is the cornea. In other words, it tells us how elevated or how depressed is the cornea. Right. So these are the factors what are what are in the output of a corneal topographer. So how do we do refractive and geometric analysis? Number one is the keratometer. We can definitely do only refractive analysis and not geometric analysis. We can do it by corneal topography, or we can do it by corneal tomography, and we can do it something by known as aberrometry. In aberrometry, you basically do refractive analysis. However, the latest equipment gives you corneal topography, corneal tomography, as well as give you aberrometry. So we'll be focusing more on something known as corneal topography. Now, what do we mean by topography? Can anyone please tell me the literal meaning of topography? Anyone, anyone in simple language, can anyone tell me what does topography means? I don't want an answer in context of eyes, but just a normal meaning of topography. Can anyone please come forward and speak about it?
Topography means measurement.
Okay, measurement of.
To study about external surface of any organ.
Okay, yes, that's close enough. That's close enough. Anybody else?
To study about the shape and the features of the certain anatomical features of the certain organs.
All right, great, great, great. So very good. All three of you gave very, very good answers. So let me tell you. So topography is a term which is generally used in geography. Okay, so topography means analyzing any surface. Suppose if you are flying in an aircraft or on a helicopter and you look at the ground. So what do you see? Sometimes you see that there is a flat surface or there is a plane. Sometimes you see there is a plateau. Sometimes you see there is a mountain, there is a hill, right? So, so the study of any surface is known as a topography. So in case of eyes, we do corneal topography. So basically what we do is on the cornea, we also try to see which area of the cornea is plane, which area of the cornea is high. Right. So basically, that is what we do in corneal topography. So it is nothing but a surface analysis of of the corneal anterior surface. Right. So it is basically the topography. The topographers are basically reflection based. Okay. So they could be Placido disc. They could be polar grid principles, and there are n number of more principles on which the topographers work. Kapil, can you please confirm if the slide is visible? Can you see the corneal topography slide?
No.
Okay, just one moment, please. And what about now? Is it visible now?
Yeah, it's visual.
Okay, can you see two photographs?
Yeah, yeah.
All right, great, great, great. So on the left side, you can see that the upper photograph is this photograph. This photograph is basically showing you something known as Placido discs. Now, what are Placido discs? These are nothing but concentric circles of a known radius. right? And on the lower side you can see this is something known as a polar grid. Okay, now these are built in a 3D manner. Okay, so there is a huge difference between the Placido disk and the polar grid principle. However, we should remember one thing, that both of them are based on reflection analysis. Right. So what is reflection analysis? We'll come to that in a moment. Now, how does topography help? Okay. When do we use topography? So the most common, the most common application for optometrists would be contact lens fitting. So if one of you is a specialty contact lens fitter, so you understand the value of a topographer in your practices or at a place where you are practicing, right? So you can, and if you can fit contact lenses based on the topographer, you're one of the best fitters, right? Secondly, for the surgeons, it is for refractive surgeries. So pre-operative evaluation of the cornea, whether to give a green signal for a LASIK surgery or a smile surgery or PRK, and so on. Then next is the cataract surgery. Now, can somebody please tell me what is the role of topography in cataract surgery? Does anyone want to give a comment on it? I put up an option of cataract surgery. So, what do you think? How can it be useful in cataract surgeries? Because cataract is present inside the crystalline lens level. So, why do we need to do the topography? Can someone please comment?
Um, yeah, there are various reasons. Most common one is to estimate the post-operative corneal astigmatism, and
Okay.
second one area where incision has to be taken.
Okay, very good. So, but the area, but the point of the incision can it be decided on the table by the surgeon? Why do we need a topographer to do that?
No, wherever there is a steepened curve, there needs the relaxation incision just so as to compromise the post-refractive corneal astigmatism.
Okay, okay, that's
So basically,
very good
to
thing.
give
Mm-hmm.
the relaxation incision.
Okay, LRI you mean? Okay, good
Yes.
answer. Okay, so there is one more thing which we missed out. That is that, suppose if a patient has undergone any kind of a LASIK surgery, any kind, hyperopic, myopic. So that kind of surgery can affect your IOL calculation. Now there could be some patients which may not give a history of refractive surgery, but they have underwent refractive surgeries. So how do we find that out? So topography could be a very good tool in finding the same out, right? Screening for conditions. So basically, suppose if you are performing a retinoscopy, the patient comes in with a progressive myopia and progressive astigmatism. So progressive astigmatism or progressive myopia. So and you perform retinoscopy, and then you see there are some scissor reflexes. You start suspecting, yeah, the cornea is not proper. Right. So we do corneal topography. We try to screen it for keratoconus or any other actinic disorders. And the last is tracking progression of corneal disorders. Now, suppose if a patient has got keratoconus, suppose there is a small ulcer on the corneal surface, and you want to keep a track of it, because at times what happens is on slit lamp examination you may not see changes in the conditions, but there are some changes occurring at a very micro level. So the topography is pretty sensitive to those changes. So it can give you very good idea about if the disease is increasing or it is regressing and so on. And it gives you lots and lots of data. So the mind behind the topography machine is a genius. We should like salute him. Right. So I'll be stuck to one machine. I'm experienced with a machine which is known as Atlas 9000. It is by Carl Zeiss, and I'll just tell you a little bit about how it works. So it is basically on Placido disk principle. It emits infrared rays at 950 nanometers, and it uses a patented technology which is known as cone of focus technology. We'll come to that in a moment. And there are large and small cones which are bifurcated and which are separated after the ninth ring from the center. Why is that? We will come to that in a moment again. And there is something known as a smart capture technology which it uses. So what happens is, in this, the smart capture technology captures 10 to 15 images per second. Right. So what the machine does is, 3 seconds before you capture it, so it is continuously capturing a lot of images, right? And just the moment you click the button to take the image, what it will do is it will analyze all the images which are analyzed, which are captured by it in the past 3 seconds, and it will give you four best images. So there is a very less operator bias in it, right? So it saves the chair time, as well as there is a lot, there is a less bias, and there is a good interoperator repeatability as well, interoperator as well as intraoperator, right? So on the left, as you can see over here, the rings are visible. So as you can see on the left image, you can see these rings. So generally these rings are not visible like this. This is visible only because we have taken it with a mobile camera. So can someone please tell me that why are these rings appearing pink when we take when we take an image from a mobile camera, and why do they appear white in the previous photograph, as you can see in the machine? So can someone please comment on that? That why pink and why white and with naked eyes? Is there any comment regarding this? All right. So I'll just tell you. So basically, I told you that these rings emit infrared rays. So these infrared rays are not visible to human eye, to the naked eye. So why infrared rays are being used? That is because it shouldn't cause any glaring to the patient while performing the topography. If there is a glaring to the patient will not be able to fix it, and if the patient does not fix it, you will not be able to take the topography image. So this is the reason why the infrared rings are being used in it. And on the right side over here, as you can see this is a cone, right? So if you can see this black region, this is a cone. We are seeing it from the front, and this is the cross section of it. So this is basically a cone. So why do they use this cone, and why after the ninth ring? So there are 9 rings over here, and after that there is a separation, and then the other rings are present on the outer side. So this is the inner circle, and this is the outer circle. And over here, why is there a separation? It is because they don't want to let any overlapping of the rings occur on the cornea. So this is a patented technology. They call it conofocus, right? This is just for the information. And what impact does this cone makes, we'll come to that in after a few slides about how does it appear on the cornea. So now, how does the Placido disc principle work? As you can see in the cartoon, in this photograph, there are two cartoons over there. So there is a man and there is a woman. Okay, they're standing in front of mirror. They're standing in front of funny mirrors. Okay, so this is a mirror, right? These two are mirrors. So this mirror, consider the mirror as cornea, right? And consider the man and the woman as the Placido disc on the machine. So what the machine does is it emits the Placido disc on the cornea, and based on the status of the cornea, it gives back the reflection. Right. So similarly, in both these images of the mirrors, so in one mirror the man is appearing healthy, and in the other image as well, the woman is appearing pretty healthy. So this is because of the curvature of the mirror. Similar thing happens over here. So mirror is the cornea. So we emit Placido disc, and there is an image forming on the cornea based on its curvature. Right. So we need to remember two things, that whenever the cornea is steep, the rings are closer to each other, and whenever the cornea is flat, the rings go far from each other. We'll come to that. We'll see an example as well. But this is how basically you can remember. So next is corneal tomography. Tomography is nothing but it measures the thickness of the cornea as well, and ultimately it gives you the posterior corneal surface as well. So it measures the true anterior corneal elevation as well, and it measures the true posterior corneal elevation as well, and as well as it gives you the posterior corneal astigmatism. And it is not just limited to the cornea, it can go beyond the cornea. It can give you the AC depth, it can gives you the status of the angles, it can give you lens thickness in the latest versions. And it can also, in some of the versions of pentacam machine, it can even give you scleral topography. So if we have any scleral lens fitters over here, I bet that you guys might have come across this term, scleral topography. But yeah, because it's not in our topic today, so we won't be talking much about it. So this is just for your information that such an equipment is also available. So next would be the maps of topography, right? The colorful map. Now, what do those mean? What are the shapes of it? How do those appear? What do those color mean? So we'll be talking about all those things in this. The following are the maps about which we will talk about throughout this lecture. Before we go ahead with the maps, I would like to ask if anybody has got any doubts. If anyone has any doubts, please feel free to ask. All right then.
I guess nobody has the
Yes.
questions. We can proceed with the presentation.
Yeah. Thank you. All right. So please confirm whether the rings images are visible on the screen or not.
Yes, sir. It's visible, sir.
Great. Thank you. So as you can see over here, as I was talking to you about the cone of focus, right? There are internal rings, there are external rings. So as you can see over here, there are these rings, and there is a big space between the other bundles of rings. So suppose if this space wasn't present, there are chances that there will be an overlapping of these rings over here, and it can give you a false reading. Right. So on the left side, this is an rings image. These are the rings images of a normal case. Whereas on the right side, if you can see, this is a case who has a keratoconus. And if you can see over here, the spacing between the rings is pretty less. And if you can see over here, the spacing of rings between the rings is pretty more as compared to this region. So this states that this area over here is a steep region, and over here it's a normal or a flat region, right? So when you capture the image, this rings images are what the is what the machine shows first. So you should be smart enough to understand that yeah, I can see some less distance between the rings. So you start thinking at the initial stage itself, so you can understand that what is going on the cornea, right? So moving further, so there are color shapes, all the maps of the corneal topography or the corneal tomography are all shown by color shapes. Okay, so in a very short this thing we'll talk about what kind of shapes are present, and I'll show you the photographs of each of them. Right, so over here there are approximately 10 images which you can see. So these are the patterns what we basically see on refractive maps of the corneal topography and tomography. Please mark my words, refractive maps. So those are axial, those are tangential, right, and so on. So yes, so these are applicable only for refractive maps and not for elevation maps. Okay, so number one over here you can see is a round shape. Okay, so and the next one is an oval shape. These two are seen when there is a very less astigmatism. Now there is something known as a superior steep and an inferior steep. These are localized patterns. What we see, we can see an inferior steep pattern in early uh, uh, pellucid marginal dystrophy. However, this is not how it always appears. But in mild cases, sometimes we can see inferior steep pattern, but it's very rare to see such a pattern. And next is the irregular. Again, this kind of an pattern is seen generally when there is very low astigmatism, and you can see such kind of pattern when there is dryness on the cornea, when there is a corneal warpage, and so on. So you can see such irregular patterns in such cases. I'm talking about normal cases. In abnormal cases, yes, you might see such patterns. Right. Next is a bow tie. Okay, we need to remember that this is something known as a bow tie because it looks like a bow tie. Right. So it could be called as a bow tie or a dumbbell. So these bow ties or dumbbells can be symmetric or asymmetric. Now, what do I mean when I say symmetric bow tie? Symmetric bow tie means both the ovals of the bow tie are equal in size, right? And the next is asymmetric bow tie. Sorry. Next is an asymmetric bow tie. In asymmetric bow tie, it could be an inferior steep pattern or it could be a superior steep pattern, right? And then there is something known as a symmetrical bow tie along with skewed radial axis. Now I'll tell you how to evaluate the skewed radial axis and what is the importance of it in the next slide. And there is something known as an asymmetric bow tie along with skewed radial axis. So what you need to remember is you first things first, what you see in a pattern is that whether it's a bow tie pattern or it's a round pattern or an oval pattern. Suppose if it's a bow tie pattern, so you have to find out whether it's a symmetric bow tie or an asymmetric bow tie. And something one bow tie is missing out in this photograph is a horizontal bow tie. Okay, I'll show it to you at the end, at the later slides in the presentation. Okay, so what we are seeing over here is a vertical bow tie, and there could be a horizontal bow tie as well. So you need to see whether it's a symmetrical bow tie or a asymmetrical, and whether it is vertical or whether it is horizontal bow tie. Suppose if it is a symmetrical bow tie, then the diagnosis is straightforward. It may be normal. Suppose if it is a asymmetrical bow tie, so you have to find out whether it is inferior stiff or superior stiff. Suppose if it is a symmetrical bow tie but there is a skewing of axis, that means both the ovals are not going straight and one of it is bending away. So you need to measure the angles between the two. Now how to measure that? We'll see in the next slide. So here we are, as you can see the diagram over here. This is a pattern which is asymmetrical bow tie with inferior steep pattern, and along with there is a skewing of axis. Now how to check the skewing of axis? Now let's consider the larger, that is the lower part of the bow as A, and the second one, the upper one as B. So all you have to do is an imaginary line is drawn straight ahead. You don't have to literally draw it, but on the topography reports you can easily see it. Okay, so basically an imaginary line passes through the A and through the at the point of intersection of A and B, and there is another line which is drawn through the center of the B and which goes through the intersection or the meeting point of A and B, and the angle between these two, it is the angle of skewing, right? So the angle between the A and the B is basically your angle of skewing. Now anything at times this could be a regular pattern. This could be present in normal cases as well. But we need to be very sure that the angles between these two should not exceed 22 degrees in normal cases. It will never, have more than 22 degrees in normal cases. So suppose if you find that there is a 22 degrees or more than 22 degrees, that means the patient is a suspect of some sort of an ectatic disorder. Right. So I hope everyone is clear. Please, if anyone has got doubt, please ask, because this is something very important and you'll be applying it in your day-to-day life. All right. I think everyone is clear about this. Great. So now there are some color scales which are present over here. On the left, you can see that there are some colors and there are some numbers mentioned over here. Now, the type of the shades, the types of the shades and the scale what is used is very important to be understood. Okay, so basically 23 different shades are used in this, but it can change from machine to machine, and there can be more than 23 shades as well, there can be less than 23 shades as well, but in most of the cases 23 shades suffice for everything, right? And there are different types of scales as well, as you can see over here. The lowest part starts from 39.75, that is the flattest region, and this is 45.25. So we have to remember that whenever there is a flat area on the cornea, it is denoted by cool colors, that is on the bluer side, and whenever there is a steep area or an elevated area, it is denoted by red or warm areas, warm colors. Okay, now same colors are applicable to elevation maps, same colors are applicable to refractive maps, same colors are applicable to irregularity maps, and so on. So we need to remember that there are three types of scales which are being used. One is something known as an absolute scale, one is something known as a normalized scale, and one is something known as custom scale. Now which type of a scale you are using signifies that how much diopters each of the shades represent. So suppose if I'm using a normalized scale, so suppose if I'm using a custom scale, so custom means you can change it. So suppose in custom I'm putting 0.25 value, so each of the shades you see over here, they signify 0.25 diopters. Okay, and what is an absolute and a normalized scale? I'll just come to that in the next slide. So as you can see a diagram over here, so there are a few circles drawn over here, right? So these, let's consider these circles as different points on the corneal topography or on the cornea basically. These are the points on the cornea. The flattest region on this cornea is 33 diopters, and the steepest region on this specific cornea is 53 diopters. Now this scale what is being used over here is an absolute or a standard scale. So absolute or a standard scale means that it is a company provided scale and it is a standardized scale. So what it will do is it will have a minimum fixed minimum value and it will have a fixed maximum value. So hence the number of shades which will be used to signify will be the fixed number, and if you can see over here it is mentioned as 1 diopter. Now what does this mean is, so each of the shades signify 1 diopter. Now what happens in this kind of a scale is, see, this scale is good for comparison between two reports of the same patient. However, what happens is, let's say that this is 33 diopters and the next spot to this is of this is 33 diopters and let's say this is 33.5. So hence there is a difference of half a diopter between the two spots, but the color step what it is using is of 1 diopter. So what it will do is after 33 it will directly change the shade at 34 diopters over here. So what will happen is it will miss out the 33.5 over here. So what it will do is it will underdiagnose the cornea. It will show less number of shades on the cornea and hence it will miss out subtle changes. Right. So when there is a standard scale, there is a standard dioptric value which each shade signify, and hence it has got a potential of missing out on subtle changes. The next is something known as a normalized or an auto or an adaptive scale. Okay, now this is a very smart scale. Okay, this is just like Google Maps. Okay, so I hope every one of us use a Google Maps. So what it does is, well, while we are traveling, suppose if we are traveling and we change a path, so what it will do is it will tell us that okay, you have changed the path, now you have to take a turn from here, now you have to take a turn from here. So it makes a new path. Okay, it is adaptive, right? So over here also this is an adaptive chart, okay, or an adaptive scale. So suppose if the minimum or the flattest region in this is 39.75, so on the cornea is 39.75, so on the scale also it will take 39.75 as the flattest region. Okay, it will not take any unnecessary flatter colors in the scale. Okay, and suppose if the steepest region in this cornea is 45.25 over here, so it will again give the steepest region as 45.25. Okay, this is the one factor. So the start and the end of the scale is signified this way, and the steps between the two shades, how is it signified? So it is basically signified. So suppose this is the whole cornea. Suppose in this region there is a 0.25 diopter of difference. Suppose in this region is 1.25 diopter, and in this region it's 2.5 diopters. So it will consider the minimum difference of the cornea. So that means, so between 39.75 and the next spot, there is a difference of 0.25. So what it will do is it will scale or it will calibrate the scale for 0.25. So what this kind of a scale does is it gives you an amplified view of any kind of conditions, right? It will give out all the subtle changes. So basically, whenever you see any kind of a topography report, whenever you take any topography report in your hand, the first thing what you should see is the type of the scale which is being used, whether it is an absolute scale, whether it's a normalized scale, whether it's a custom scale. So suppose if a patient comes in with a report in your and gives you the report, okay, this topography was done and I'm diagnosed with keratoconus. So suppose if you repeat the topography at your hospital, so there are chances that the appearance may appear different. I mean, the appearance may be different, even though the topography was done on the same day or just 2 days prior to your examination. Why it might appear differently? Because of the type, it will appear differently based on the type of the scale which is used. Right. So you have to keep a very vigilant eye on what kind of a scale is being used. Now, what difference is it going to make on topography reports? Okay, I'll show you a live example. So on the left side, you can see that they have used uh, a standardized scale or an adaptive scale, an adaptive scale, sorry, not standardized. And on the right side, they have used a standardized scale. I'm sorry for but the image is very blur. But if you can see over here on the right image, the steepest is somewhere in 50s and flattest is somewhere in 38. Whereas on the cornea, there is no area which has got 38 diopters or 50 or more than 50 diopters. So there is a step of more than probably one diopter, right? The step, each of the regions are signifying one diopter, let's suppose. So it is giving an appearance of irregular astigmatism. Okay, but if you see on this side, okay, the minimum is somewhere around 42 or something and the maximum is 47. So if you can see over here, it is giving you a more amplified view of the irregular astigmatism. If you can see, it appears more irregular as compared to this. If you can see over here, there are more shades of color as compared to the right side image. So this is on the left side, what you can see is an adaptive or an auto scale. On the right side, what you see is a standard scale. Right. So the standard scale does not take into consideration the dioptric differences between the two points, and the normalized scale or the adaptive scale takes into consideration the minimum step between the two different points on the cornea. Right. So this is basically the scales. Now, since we have understood about the scales, let's talk about the axial map. What is an axial map? Okay, so this is one of the most simplest way to describe the corneal shape, or describe the corneal keratometric values, in a graphical manner. Can you please confirm whether the axial curvature slide is visible? All right. So it is one of the simplest way. Okay, but there is a negative point in this. It is that it considers the cornea to be a spherical surface. Right. So, but which is not true. The cornea is not a spherical surface. It is an aspheric surface. So, when can you use an axial map? Axial map can only be used when you want to grossly evaluate the anterior surface of the cornea. Right. Now, how does the axial map? How is the axial map calculated? Let me tell you. So, let's suppose this is the cornea. Over here is the cornea. This is an optical axis. Okay, the dotted lines what you see. So what it does is, suppose this is our point of interest. Suppose I want to find out the dioptric value at this region. So what it will do is it will just measure the distance from this point of interest to the optical axis. So the one assumption which is made over here is that the cornea is a spherical surface, because there is a fixed optical axis which is being used. Okay, so now what happens is that this axial curvature map misses out subtle changes. Okay, why does it miss out the subtle changes? First I will explain you the tangential curvature, then you will understand why does it miss out the subtle changes. Okay, so tangential maps, it is also known as local curvature map. Okay, so now what it does is it basically, it does, first things first, it does not consider the cornea to be a spherical surface. It considers the cornea as an aspheric surface. Okay, now let's say the same image but with a different drawing. So over here, if you can see that this is the cornea, and over here is the our area of interest or the point of interest. So now what it does is it draws a tangent. Okay, what is a tangent? Tangent is any arc which is drawn, okay, and which touches any imaginary circle or a circle only at one single point. Okay, so over here, if you can see this tangent arc, it is drawn over here and it touches the cornea at only one single point. Okay, so this arc is taken and it is completed as a circle over here. Okay, it is completed as a circle. Let me repeat myself. A tangent is drawn, okay, and that tangent is taken is then completed to be as a circle, and the radius of this circle is considered to be the radius of curvature of that specific area. Now we have measured the radius of curvature, but we want a dioptric value. So basically the formula is used and this radius of curvature is converted into dioptric value, and it gives you the map as you can see over here on the left side of the screen. Now, as I was telling you that there's a difference between the two. The tangential curvature does not miss out on subtle changes. Actually, it is very good for to evaluate subtle changes. It is very helpful in healing conditions or worsening conditions, whether you want to keep an eye on the subtle changes on the cornea. Okay, so I'll show you the difference between the axial and the tangential curvature. But let me tell you about axial and tangential curvature one more time in a very simple language. Now, all of us have been to school and classes during our childhood ages, right? So there is a difference between the teacher in a school, and there is a difference in the teacher in private tuitions or private tutors or classes. Now, what happens in the school? Now, suppose there are four kids sitting on the last bench. The teacher is going to consider all four of them as mischievous, right? Because they are sitting on the last bench. But there could be a possibility that one of those kid is not, mischievous guy, but the teacher is ignoring because that kid is sitting on the last bench. Whereas on the other hand, the school teacher, when they see the kids on the first bench, they consider all of them as scholars or as very good kids and everything and so on, right? So basically, the axial curvature map is something like a school teacher. Okay, it does not take into consideration that there could be some local discrepancies. So what do I mean by that is, suppose over here, this is a very steep region. There are chances on the cornea that this could be a flat region as well. But because this considers the cornea as a spherical surface, it may ignore or it may fail to get a subtle change over here. So what do I mean to say is, suppose if this area is steep and there is one single area which is flat over here, it may miss out. It may not show on the axial curvature map. Whereas on the other hand, the tangential curvature. Now, tangential curvature is like a private tutor. Okay, what do private tutor do is they basically keep one-to-one conversation and one-to-one attention on all the students. Okay, it does not matter where is the student sitting. It does not matter whether the student is sitting on the first bench or is sitting on the last bench, is sitting close to the teacher or away from the teacher. The teacher does not classify the students based on that, but the teacher classifies based on one-to-one experience with the kids. Right. So in tangential curvature, suppose this region is steep, and suppose there is a flat region which is present over here. So it will show you the flat region as well. Okay. So that subtle change is always visible on tangential curvature. And if you can see over here that there is a lot of smoothing, if you can see the pattern is very smooth on the axial curvature map on the left side. Whereas on the right side, tangential curvature, you can see that, yeah, there is, change in the colors, but it is not smooth. It is very sharp. If you can see over here and over here, there is a very sharp change in the shades. Over here you don't see such sharp change in the shades, right? So in axial curvature, one more negative point is that, if there are things in the periphery, or if there are subtle changes occurring in the periphery, it may tend to mask them. Whereas on the tangential curvature, it will not mask them because it is analyzing one point at a time. Right. So as I was telling you that, in tangential curvature, a circle is drawn, a circle is completed when an arc is drawn. So this is a graphical representation of the same. So as you can see over here that an arc is drawn of 43 diopters of basically 43 is signifying 43 diopters. So an arc is drawn over here, then that arc is completed to be a circle, and the radius of this circle is considered to be the radius of curvature of that specific point on the cornea, and then using the formula it converts it into dioptric values. I hope this is very much clear to all of you. The next would be an elevation map. Now, what is elevation? Elevation is nothing but, how much cornea is high, right? Elevation literally means that how much high is any surface, or in this case, cornea. So, elevation map. Now, suppose if I want to say that my height is very high, or I'm very tall. How do we define tall? So, tall, when I want to say I am tall, I should have a reference. I am tall as compared to whom? Right. In other words, in geography, what do we see whenever there is a mention of any kind of plateaus or hills or mountains? For example, Mount Everest. So the peak of the Mount Everest, it is sometimes written as XYZ meters, but meters from where? XYZ meters from there. I'm sorry, I don't know exactly how high is Mount Everest. So suppose if it says 2000 meters above the ground, so it is saying above the ground, right? So the ground is taken as a reference. So in elevation map as well, the elevation map is made based on a reference. So what it does is, so whatever the findings we have got from the corneal topography analysis, so this data is compared to something known as a best fit sphere. Okay, now what is a best fit sphere? Let me tell you. Okay, as you can see over here, there is a complete curve over here, and there is a dotted curve. Okay, the dotted curve is a best fit sphere. Okay, and there is a something known as there is a complete arc, which is the cornea. Now this cornea is compared with this best fit sphere. Now what do I mean by best fit? Okay, so this is a circle, or this is a sphere which is almost same or almost equal in curvature to the cornea, to the patient's cornea. So what it will do is it will just superimpose both of them, and it will see how much high is the cornea as in reference to the best fit sphere. So in this area, if you can see over here, it is higher. It is higher as compared to the best fit sphere, means it is elevated over here. And elevation is signified by warm colors. On the other hand, if you can see over here, this best fit sphere is higher than the cornea. That means the cornea is depressed in this region as compared to the best fit sphere. Right. So over here it will be signified by cool colors. So in other words, the cornea acts as acts as Mount Everest, and the best fit sphere is the ground. Okay, so you have to measure the distance between the two. I hope you are following this. So yes, so this is something known as an elevation map. However, we need to remember that this is not a true elevation map, because it is comparing it with a best fit sphere. Okay, it's sphere, whereas the cornea is a aspheric surface. On the other hand, we need to remember that all the steep points are not elevated, and all the flat points are not depressed. We need to remember that always. You know why? Because an area can be steep and in reference to some other area on the cornea itself, right? So the best fit sphere which will be used, it will be very much different. Okay, so sometimes it masks some elevation, and sometimes it masks some depression as well. So basically you should understand, after you see a few elevation maps, then you will follow that. Okay, not all the steep points are high or elevated, and not all flat points are depressed. But the elevation map on the elevation map on the corneal topography are not true elevation, because as you can see this photograph over there, it's a photograph which is captured from a helicopter or from a drone. Okay, so from here what we can see is we can see the rooftops of all these tall buildings. But can you but can you please can anyone tell that what is going on in the ground floor? No, we cannot. That's not possible, because we are looking from a we are having a aerial view, right? So we can come to know what is going on the rooftop, but we cannot analyze what is going on in the ground floor, right? So similarly, the corneal topography's elevation is just like this. Okay, it will tell you what is going on the rooftop, that is, it will tell you what is going on the interior surface, but it will not tell you the true elevation, because you don't know what is going on in the ground floor. I hope everyone's following this. Right, so we'll move further. Now there is something known as an irregularity map. Irregularity map. Now this is a successor of elevation map. Now what it does is how is this irregularity map created? So basically what it does is it takes all the values from the elevation map and then it compares it with best fit aspheric surface. So let's say that a cornea is elevated by X amount and depressed by X amount in some regions. So is this elevation and depression normal? We cannot practically remember all the values, right? So there is a maps, something known as an irregularity maps. So this irregularity maps has a data of normal patients, okay, normal elevations. So what it does is the elevation maps are compared with aspheric surface, best fit aspheric surface, and the data which is derived, it is compared with the normative data, and then it tells you whether it is regular or irregular in the given regions. Again it is given in microns. The elevation is given in microns as well as the irregularity is given in microns. Again the same thing applies over here. Suppose if it's on the warm side of the scale, that means the areas are elevated. Suppose if it is on the cool side, that means it is depressed in that area. Right, so next is a keratometric map. It's a very beautiful map. Believe me, all the contact lens fitters, especially the RGP lens fitters, this is a boon for all of us. Right, so it gives you all the local keratometry readings on both the meridians, on the submeridians, right? So on the flat area and on the steep area. On the left side, you see there is something known as scene case. Now, what is scene case? Scene case is basically an average, which is average of the central 3 millimeter region. Then it gives you in geographical regions. The first is the central region, which is 0 to 3 millimeter. It tells you how much is the keratometry reading over there. There is mid periphery, that is 3 to 6 millimeters. That tells you the keratometric readings over there. And there is periphery, which is 6 to 9 millimeters. Right. So this tells you about any local, steepening or local flattening. So this will help you very much in choosing which type of RGP lens to be fitted on the eye. What base curve should be chosen. So this is a very beautiful map. I personally love this map a lot. This keratometry map. If one is given just a keratometry map and CL has to be fitted, RGP has to be fitted, believe me, you can fit and you don't need the whole topography reports. This is a really a beautiful map because it gives you all the regions, right, from 0 millimeter up to 9 millimeters, right? And yes, one last thing I forgot to mention is that it gives you eccentricity values at various meridians. What is eccentricity values? That how fast there is a flattening of the cornea. So suppose if a patient has keratoconus. So let's say the keratoconus is in this region. Okay, there is a steepening in this inferior region. So eccentricity value of this region will be high because there is a sudden flattening which will occur on the adjacent point to the cone. Whereas on the other hand, in a normal cornea, you see there is a gradual flattening towards the periphery. So the eccentricity will be low. Okay, so next is a refractive power map. Okay, first things first, this should not be confused with axial or tangential map. Okay, because there is a difference between the two. The axial and the tangential maps measure your
measure your keratometric values in millimeters, and then it converts into the dioptric values. Whereas on the other hand, the refractive power map measures directly the refraction of the light. So it is also known as Snell's law map. So there is a pre-fed refractive index which is present in the machine, and then based on the an analysis from the placido discs, it tells you how much diopter the values are on each regions of the cornea. So it basically, it does not tell you structure of the cornea, but it tells you about how the light is going to behave from each region. So at this point, how is the light going to refract? At this point, how is the light going to refract? At this point, how is the light going to refract? And also it takes spherical aberrations into consideration. So basically, as I told you, it tells you individually from where the light is going to refract. So refractive power map could be again a very useful tool in understanding your patient's symptoms. Okay, suppose if a patient comes in and and they are telling post LASIK patient comes in and the patient tells you that I'm not happy with my vision. Okay, so over here you can find out that what is going on exactly in different regions of the cornea. There could be a region in the center of the cornea which is not behaving as it should behave, or it is not refracting the light as it is supposed to. So it can give you a little bit of idea about what is the patient seeing. But again, you cannot rely 100% on this, because this is just the anterior surface of the cornea, because the light goes through the anterior surface of the cornea and then passes to the posterior surface and through the aqueous and so on. Right, but yes, it gives you a very fair idea in cases with refractive surgeries, because you can compare the refractive maps of pre-op and post-op surgery, and then you can find out what is going on exactly. Next is a mean curvature maps. Now again, this does not need to be confused with axial and tangential, because in axial and tangential also curvature is measured, and in mean curvature map also curvature is measured. So now what is the difference between the two? First things first, you have to remember that in axial and tangential maps, the measurement is done in submeridians, that is on the two principal meridians, right? Semi-meridians, I mean, so not submeridians, sorry. In the two semi-meridians, that is the steep axis and the flat axis, right? But in the mean curvature maps, what it does is it takes an average of each and every points. Okay, so suppose if this point has to be analyzed, so steep meridian of this and flat meridian of this specific points, it is taken and it is averaged out, and then it gives you the curvature of this specific region. The best part about this is that it does not it basically suppresses the non-pathological features basically. So suppose if on tangential map, if you're looking at a with the rule astigmatism, but there is a point somewhere. So suppose if you're looking at a with the rule astigmatism, and somewhere in the dumbbell there is an abnormal point on the cornea. Now this abnormal point may be masked under the with the rule astigmatism pattern, but if you look at the mean curvature map, that area will be shown. That area will appear to be an abnormal area. Again, the same kind of color scale is used, color palette and color scale is used on the left. The red ones signify the steep regions, and the blue ones, or the warm or the cool colors, signify the flat regions. Right. Now, mean curvature maps. Okay, let's look at the comparison between the mean curvature and the axial curvature maps. As you can see over here, this is a vertical dumbbell. Okay, this is a vertical dumbbell with a symmetrical bow tie pattern, right? But this is the same analysis of, it is the same eye. Okay, it is the same cornea. So if you can see, this is showing more of Victoral astigmatism. This is showing more of a astigmatism part, but this will not show you the astigmatism part, but it will show you the dioptric values of each and every region. Okay, similarly on the left eye, it is the same patient with, this is the right eye, this is the left eye. Again, over here we can see a vertical dumbbell, which is a symmetrical bow tie, or a symmetrical dumbbell pattern. And over here you don't see any such pattern, but what you see is where the area is steep and where the area is flat. Now, when is the mean curvature used? First things first, if you need to analyze that, how is your ortho K lens doing? How is the result post-operative in LASIK patients? So you can find that out in this. And there are a few values which we acquire from the uh, from the mean curvature map. All these values are later words used in something known as a Pathfinder 2. Now, before we proceed with this, I would like to ask the organizers that do we need to take a break for 2 to 3 minutes or 4 minutes, or shall we continue? Because we want the people to focus, and I think I'm speaking since 40-45 minutes, I think so. Not sure. So the attention may be an issue.
Okay. So it was going so well because I guess everyone living on your sharing knowledge. So I will review some of the questions if they are asking, and we'll be continuing the presentation.
Yeah, sure. We take a few questions. Yes, we
Okay.
take a few questions before I speak any further, and then we can go on. Please come up with questions. And if someone is typing questions, please dictate the questions to me so I can answer them.
Okay, if anybody have the question, please just pop on our chat box. Either you can unmute yourself and ask the question.
Either everyone has understood everything, or else I am very boring and I've made people sleep.
So it was so good. Okay, so can we? So we will be continuing the presentation, and will be okay. So there is one question from the Ajay Kumar, I guess. In the refractive power map, what does hotter and cooler color mean, sir?
Let me just go back to the map. Just one moment. Yes, tell me. In the refractive error map, the color map, you mean?
Refractive, yes. What is the color? What is the color means? Hotter or cooler in refractive power map, sir?
Yeah. See, basically, refractive. Now let's remember refractive. Refraction comes in diopters, right? So basically, on the left side, what color maps you are seeing, it signifies the dioptric values. So this is refractive power. Power is again diopters. So all the warm colors, they signify more diopters or the steep cornea, and all the cool colors, they signify your flat regions or your less power. Right. So this color maps are similar to the axial and the tangential maps. So there is no difference between the the color grading or the nomenclature between refractive power and axial and tangential maps. Is this clear?
Yes. Okay,
yes,
so it was. So there is another question. Which type of map is commonly used from the Radhika?
That's a very good question. If you talk about commonly, then most of the people use axial map because it looks nice and it is very easy to interpret. But if you ask me personally, it's not the axial map that we should always look at. I think we should look at a tangential map because it will give you subtle changes as well. So where there is a very less proportion of people who use tangential map. So let's just not talk about which people use what, but if you ask me, the best suggestion would be that you should use tangential map in order to see, in order to evaluate corneal topography, because you will not miss out on anything. And if you can use normalized scale, as I was telling you in the initial stage of the presentation, if you use a normalized scale, nothing like it, you can evaluate the topography very beautifully, and nobody can challenge your topography result or your topography diagnosis, because it will be very perfect.
Okay, sir. So is there any effect on corneal topography with the patient with positive angle kappa?
Which angle kappa? Please speak again. I couldn't hear properly.
Okay, sir. Sir, is there any relation? Is there any effect on corneal topography in the patient with positive angle kappa?
Oh, yes. There could be. There could be. Okay. See, basically, what happens is angle kappa. What is the? So it is basically how far is the visual axis from the center of the cornea, right? So it is that there is the angle kappa. So now what happens is the fixation would be wrong. So the vertex which is found out. Okay, the vertex of the cornea which is found out, that could be a wrong area, but on the other hand, the vertex is nothing but your fixation, right? So it is the first Purkinje image. Okay, vertex is found out by the first Purkinje image. Now this also depends upon the person who is looking at the topography report. Now suppose if you are aware that what is positive angle kappa, or it appears in high hyperopes, so you will understand, okay, the apex is moved on the nasal side, so you are aware that yeah, this could be a high angle kappa. So what you can do is you can repeat the you can repeat the topography and just confirm it second time. But suppose if you're using a machine known as a pentacam or an eye tracy, so in that in eye tracy especially, they write angle kappa. Okay, so in that you will not get any confusion. But if you're talking about just the topographer, yes, you might get confused that okay, what is happening? If you look at the reports very critically, and suppose if you are smart enough to understand that why is this vertex displaced, okay, so you can tell the surgeon, or if the surgeon observes this, so the decision can be taken based on this about the refractive surgery. So a paracentral ablation can be done for myopics or hyperopics and so on, whatever refractive surgery the patient is undergoing. So
Okay,
yes,
yeah,
it can be useful.
okay. Okay, sir. There is another question from the Amit Kumar Singh. Thank you so much, sir, for question.
Yes,
So, sir, how
yes.
could we differentiate the terrestrial marginal corneal degeneration from the pellucid marginal corneal degeneration with axial mapping?
Difference between whom you said? Please come again.
Uh, yeah, TMCD, terrestrial marginal degeneration, or PMCD, pellucid marginal degeneration.
Okay, basically TMCD, what we see is I have just come across just one single case of TMCD. So what we had seen in that case, it was on the superior region. Okay, so the area of the affected region was totally different because it was on a superior side. And in on PMC and on PMCD, what we see on pellucid marginal dystrophy, what we see is it is more towards the limbus side, and it is generally seen between 4 to 8 o'clock, right? And what you see over there is a kissing dove pattern. So we'll be coming at a later stage. I don't have a Terian's map on this, but I do have a slide which can tell us very nicely that what is the difference between the pellucid marginal dystrophy versus keratoconus. Right, I unfortunately do not have the other map, the Tyrians, but I'll make it a point once I reach the hospital, then I'll share the photograph with you, so you can share it with the person, with my friend who has asked the question about this. And yes, that's how it is. I don't know much about on specifically on axial map how would we discriminate between the two, but I think based on the position, yes, we can discriminate.
Okay,
So if
so
anyone has any different
yes,
answer than this, then please come ahead and you can answer this.
Okay, so I guess it's also depend upon the definition, because the origin of
Yes,
thinning was completely
yes,
different between the terrestrial margination and pellucid
yes.
margination. So we can also go through the by the other clinical significance, right, sir?
Yes, definitely.
So, sir, there is another question from the Rahul Dot. So he is
Yeah.
asking. Yes, sir. You said that the keratometric topography is so much important for RGP feature. But my question is why we need that we decided back optic zone radius based on only the central corneal reading is measuring the corneal keratometry instrument.
Just a moment. Let me just read the question on the other phone. I'm sorry, I couldn't follow you fully. So you said the keratometry topography is important for RGB fitting, but my question why do we need a can Mr. Rahul can he turn on his mic? We can have a very good conversation on this. It's a very good question, but yeah, Mr. Rahul, can you please come on the mic if you don't mind?
Yes, sir. Yeah.
Yeah, very good, very good. Thank you for turning on your mic. So basically, you asked me that why we can fit it based on only on the central. So can you please tell me what diameters RGPs do you fit basically if you are personally fitting? Can you just
Sir,
tell me a
actually,
couple
I'm
of
not a RGP
lenses?
fitter.
Okay,
Actually,
no
I'm not
problem.
RGP fitter. I am a student, sir, but we have fit RGP diameter as 7 mm, 8 mm diameter.
All right. Good. Thank you for your answer. So basically, see, what I personally fit is starting from 6.9 mm up to 11 millimeters of RGPs, right? So tell me one thing: that do we fit RGP only on the center? No, we do not fit RGPs only on the center. But there is a region which is known as the central, there is a region which is known as the mid periphery. There is a region which is known as the mid periphery, and there is something known as an edge lift, right? So the RGP has got a relationship with the cornea throughout, right? So suppose if I am fitting a 10.5 diopter, 10.5 millimeter RGP on a cornea, so that does not mean that there is a relation with the cornea only in the central region, but it has got a relation with the cornea up to the 10 diopters or up to the 10 millimeters of its diameter, right? So it is the
Yes.
central cornea which is. I'll just show you that map as well. Yes. So if you can see on your slide over here, suppose if I'm fitting a cornea of fitting a RGP lens of 9 millimeters, so that does not mean that only this region is important or only this region is important, only this region is important, but all the regions are equally important. Now let's say that you are fitting the RGP lens based on only central 3 millimeter keratometry, and suppose if there is a abnormally steep or flat region over here, that is 3 to 6 millimeters. I think one of our friends is bothering us from the background. Can we
No
please get
problem.
rid of that? Even he is very fond of learning, I think so. Okay, so as I was telling you that suppose if we fit the RGP, if we choose the base curve based on the central 3 millimeters, and suppose if there is an abnormal steepening or flattening in this 3 to 6 millimeter region, so there could be some unwanted or surprising fitting errors or fitting observations that you might observe in the 3 to 6 millimeter area of your cornea. So suppose if you choose based on this, you might get a false reading somewhere else. But if you choose your first RGP trial lens based on the whole keratometry, so your number of trials would reduce, your chair time will also reduce, and the confidence the patient will have in you will be better, because you are doing your thing very quickly, right? I hope you're following me.
Yes, sir.
So this is why I
And
told you that geometry map would be very much useful. I know most of the people can fit RGPs based on the central 3 millimeters, but what I'm talking about is not normal cases, but I'm talking about the abnormal cases, ectatic disorders, or post traumatic and so on, right? So keratometry
yeah.
map would be used in such condition, right? I hope
Okay, sir. Now I got that.
right. Yes, very good. So do we have
Thank you,
any more
sir.
questions? Welcome. You're welcome.
Sir, yes, sir, there is another question. But sir, it is better, I guess, continuing with the presentation and in the discussion on the in the session, because it will be going so long. That's why. Can we say?
All right. Yes, yes. Okay, okay, no problem. So whatever the if a person has asked the question, so we will answer him or her in the end of the session, right?
Yes, sir.
Great, great, great. All right, then let's move on. Yes. So what are the measurements that we achieve or that we get from the mean curvature? So before I move further, let me tell you all these measurements what we acquire from the mean curvature map or the mean curvature technique are going to be used laterwards in analysis in a map which is known as a Pathfinder 2. Okay, we'll come to that, what is that and everything. But yes, I'm just giving you a little bit of heads up. So what different values is it going to give us? So the number one value that it gives us, it is the maximum mean curvature. Okay, so what is maximum mean curvature? The name only signifies. So how much? How much is the maximum curvature present on this specific cornea? The second is the x and the y coordinates of the maximum mean curvature. Now someone was talking about, we were talking about angle kappa. Now there is something known as corneal apex and there is something known as a corneal vertex. Okay, what is the corneal apex? That is the steepest area, basically nothing else but the steepest area. Okay, so the maximum mean curvature tells you the steepest area, and secondly x and the y coordinates tells you that where is the steepest area in respect to the vertex of the cornea. I will say again, it tells you x and the y coordinate tells you that where is it present, where is that point present of the steepest area, how far it is from the vertex of the cornea. So vertex is basically nothing but the first Purkinje image. It is the place from where the patient fixate. It is the line which reaches your fovea. Okay. So the third thing what it tells us is the x and y coordinates of the centroid. Now what is centroid? I'll tell you what is centroid. So first we understand what is convexity. Now everyone knows that what is convex, right? So we all know what is convex and what is concave. Now I'll tell you what is the convexity. So basically this convexity value tells you that how much convex is this specific cornea. Okay, anterior surface of the cornea, how much convex it is. Now how can we measure the convexity? Okay, now in this diagram there is a yellow circle which is drawn. Okay, this yellow is the cornea. Okay, in all the three images. Okay, on the left side what you see is the cornea when we see it from the front, and the right side two images what we see is the cross section. Okay, and there is a line which is I'm pointing out by the pointer that there is a line over here, a curved line over here, which is pointed out to be a convex hull, HULL hull. So what is a hull? Hull is a term which is used in in the by the sailors, the ones who sail the boats. Okay, they call that the hull of a ship, hull of a boat. What is a hull? Hull is nothing but the outer surface of any structure. Okay, so there is something known as a convex hull. So this convex hull is like a reference which is placed on the cornea. Okay, and then it is matched with the cornea. Okay, it is a convex structure which is matched, it is an imaginary structure which is matched on the cornea, taking the corneal steepest point into consideration. So in the over here the central most area of the corneal hull, or from where it starts, is basically the steepest part, and then based on that the hull is drawn, okay, on the cornea. Now if you can see in this image, okay, so this is a less convex cornea. So that means you see that the hull is touching at more regions. Okay, it is touching the cornea at more regions, whereas you can see on the lower side the cornea is more convex. Okay, it's like an oval shape. This is just like a steep cornea, or just like a cornea which is a keratoconic cornea. So in this region there is a less touch with the convex hull, so it means this is more convex area. Okay, so now when I told you the x and the y coordinates of the centroid is nothing but the steep area from which the convex hull starts on the cornea. Okay, and what is the convexity? Convexity is basically the proportion or the ratio between this convex hull and the convexity of the cornea. This value can vary between 0 to 1. Okay, so 1 signifies more convex and 0 signifies less convex. So suppose if we see a patient with a keratoconus, the patient may have a value of 1 or closer to 1. And suppose if we see a patient who has underwent LASIK surgery, a myopic LASIK surgery, we'll see the we'll see the convexity value of less than, I mean, towards more towards 0, and in this kind of cases we'll see more towards 1. Right, so this is something known as x and y coordinates of the centroid as well as the convexity. Okay, the next three values, what it shows is basically the mean inferior superior difference, mean inferior nasal and superior temporal difference, and the mean inferior temporal and superior nasal difference. So what is it basically? So number one thing, we have to remember that these regions are situated 2 millimeter away from the vertex. So 2 millimeters. So suppose if I'm talking about I and S, let me just show you the graphical representation. Yes, so on this coloring map, as we can see over here, so it is the first things first, let's talk about the superior. This cross, what we see over here is the vertex. Okay, we have to remember that the vertex is signified by a cross. So this is the corneal vertex, 2 millimeter superior is the superior region. Now we have to remember that all these squares, all these regions are of 1.5 by 1.5 mm squares. Okay, so first things first, it tells you the superior and inferior, the difference between the superior and inferior. So this is the superior 1.5 1.5 by 1.5 mm, and it is at 90 degrees. And the inferior is, so if you can see, there is a degree scale on the over here, just like a protractor, right? But it is a 360 degree. So superior is at 90 degrees, inferior is at 270 degrees. Now there is superior nasal and inferior temporal. So it basically tells you the readings in cross or in the opposite regions. Superior temporal and inferior temporal, 2 millimeters away from the corneal vertex, size of 1.5 by 1.5 mm, and the superior nasal is situated somewhere around at 130 degrees, and the inferior temporal is situated at around 310 degrees or 320 degrees, somewhere around that. Right, inferior temporal and inferior nasal and superior temporal regions. Now these two areas are compared. So inferior temporal is present somewhere around at 250 degrees, and the superior temporal is somewhere situated around at 45 or 50 degrees. Right. So these areas are basically measured, and it tells you the difference between them. Now, how do these differences appear? We'll come to that in a moment. Okay, before going ahead, we will talk about a little bit more what it tells us. There is something known as a corneal irregularity measurement. That how much irregular is the cornea? It gives you an average value of throughout the cornea. There is something known as a toric keratometric mean. Now, these tells you that how much astigmatism is approximately present at the steepest region. Okay, as I told you that it tells you curvature at each and every points on the cornea in the mean curvature map. So it tells you that how much is the toricity at the steepest region, and the last is the shape factor. Now, can someone please tell me that what are the different shapes of cornea? Is anybody aware of that? At least one shape, at least just one shape, if anyone can say. Okay, yes, someone has.
So it's parabola,
Yes, and
hyperbola,
uh-huh. You are close, but I'm expecting some different type of words.
Oblate shapes, huh?
Yeah, yeah, perfect. Oblate and
Prolate, sir.
yes, very good. And one more is there. Hyperprolate.
Okay.
Right. So yeah, yeah, very good answer. Very good answer. Thank you for answering. So basically, the different shapes are oblate. The number one is oblate. So what is oblate? Oblate means the central region of the cornea is flat and the peripheral region is relatively steep. Right. Next is a prolate. The cornea, naturally the cornea is prolate, central steep and periphery flat. Now there is something known as a hyperprolate. Hyperprolate means the central has become more steep and the peripheral become more flat. Right, so these are the different shapes. Now all these shapes have got its own value. Okay, so whenever, now we have to remember one thing, the q value. Q value is something known as the asphericity value of the cornea, and the shape factor is opposite of it. So the sign, so suppose if I say that a cornea has got an asphericity of -1, so the shape factor is going to be +1. Suppose if I say that the q value is -1/2, shape factor is going to be +1/2. Right. So we don't write plus before a half. We just write 0.5. Okay. So we need to remember the shape factor. Now the shape factor, when it goes into negative, that means the cornea is oblate. And when the cornea, when the shape factor goes towards the positive side, it means the cornea is prolate or hyperprolate, or the cornea is steep in the center. I hope everyone is following me. Right. So these are the few values which are measured in the mean curvature map. Now there are color codings for each and every values over here. As you can see the chart over here. So there is something known as a percentage of population. Okay, when it for there is something known as a percentage of the population. There is something green, yellow, and red. So any values which are highlighted in green, that means they are normal. That means these kind of values are observed in 90% of the population. Now please let me remind you that this machine compares all these data with normative values, or normative data are already fed in the machine. That's why I can tell you in red, green, and yellow. Okay, if you see a value which is in green, which is mentioned in green, it means it is normal. Suppose if it is mentioned in yellow, it means it is borderline, and you need to have a correlation with the clinical findings. And suppose if you see it in red, that means yes, this is a high probability that it is an abnormal value. Right. So you don't really need to remember all these values, right? Except for the Q value. Q value is not mentioned over here, but except for the Q value, that will come to that at a later stage. But if you can remember the shape factor, then you automatically remember the Q value as well. So suppose if the shape factor is going, in 0.65 or 0.85 in the plus value, so that means you start suspecting, and this cornea is pretty steep, right? So if the cornea is getting steep, that means it is getting prolate, and if it is getting prolate, it may be a sign of developing any kind of ectatic disorders, right? And so on. And in the red values, if you see such values, now let me tell you something that in yellow and red you will always see that values in red especially, you will see values on both the ends of the on both the ends. It's on negative as well as it's in positive. Negative, it comes when the cornea is excessively steep, and positive comes when the cornea is excessively steep, and negative value comes when it is excessively flat, right? So that's how it is. So basically you need to keep an eye on what kind of a cornea it is. So it does not mean that when you see a steep cornea, at that time only an abnormality has to be there. It's not that way. If the cornea is excessively flat, then also there is some kind of an abnormality. Right. So now let's have a look at this. This is the mean curvature map of a keratoconus. So now let's start from our basics. So first things first, what we will look at is the type of the scale which is used. So it is a custom scale, and if you see something over here is known as an expanded colors. So in this, more than 23 shades of the colors are going to be used. Okay, so the minimum value which it is using is 31 diopters, maximum is 67 diopters, and it is at a 1.5 diopter step, right? So in this region, now this is the vertex of the cornea. The X represents the vertex of the cornea, and the triangle depicts the apex of the cornea. Apex means the steepest area of the cornea. Now let's have a look at the maximum mean curvature is 54.9 diopters. Now it is signified in red colors because and this is an abnormal thing.
Now mean x and y positioning of the maximum mean curvature. Now if you see in the x-axis it is plus 0.5. So let's say on the x-axis it is 0.5 and on the y-axis it is minus 1.4. That means it is going lower to it, right? So on the y it is going lower and a little bit on the right side. So that means this is the area of your apex. This is the position of your apex. So this is similar to the coordinates of the maps what we see, longitude and latitude. So similarly x and the y axis, right? Now there is something known as a centroid. As I told you, centroid is the position of the hull, from where the hull is measured, from where the hull is situated. So hull starts from here, sorry, it starts from here, okay, in respect to the apex of the cornea, okay, and then it basically measures your convexity. So basically a hull is drawn here and here like this, and it gives you the convexity. So this over here, if you can see, the convexity is 0.95, which is close to 1. So that means this is a steep cornea. This is more convex cornea. It is more hyper. It is basically a hyperprolate cornea, right? Now there is something known as a mean inferior superior, right? So there is a difference. So inferior, so it is basically 2 millimeter away in the inferior side, 2 millimeter away on the superior side, right? So at 90 degrees over here and 270 degrees over here, there is a difference of 9.1 diopters. This is a very huge difference. Normally, we should remember there should be no difference of more than 1.5 diopters if inferior region is steep. I want everyone to note this down on your books and make it like a tattoo in your brains. That inferior superior difference, when the inferior region is steep, it should not be more than 1.5 diopters. If it is more than 1.5 diopters, please start suspecting the patient for keratoconus. And suppose if there is a superior steep pattern, and if it is more than 2.5 diopters, then also you should start suspecting some sort of atypical ectatic disorders. Okay, so when there is an inferior steep pattern, more than 1.5 diopters, start suspecting. Superior steep pattern, more than 2.5 diopters, start suspecting. Right. Now let's look at the mean inferior nasal and superior temporal. Okay, inferior nasal and superior temporal. The nasal is already mentioned over here, temporal is mentioned over here. Inferior nasal, inferior nasal and superior temporal region, there is a change, there is a difference of 8.3, it is mentioned in red. In inferior temporal and superior nasal, 9.6, again it is mentioned in red. So that means if you look at the trend over here, in all the cases the inferior region is pretty steep, right? So it means that inferior region is steep on this cornea. So this is significant of a keratoconus. Right. So if you see a few of these cases, then you will start understanding that, okay, yeah, this is how it basically works. These are the types of the cornea will give this kind of features and so on. Let's go on with the corneal wavefront. Okay, so this basically is nothing but a wavefront map. Now, what is wavefront? It is basically a comparison of the wavefront which is sent to the eye and the type of the wavefront which comes out from the eye. Okay, I'm telling you in literal terms. Okay, so this is basically a comparison between the image quality. Okay, so suppose if you are sending in an object, the light rays from a point object, okay, entering the eye should form a point image. It is simple as that. However, what happens is, because the cornea and the lens are not not aberration free optical systems, hence there are some aberrations. So the light of rays which will be coming out of the eyes again will be of different wavefront, right? So this wavefront basically tells you that how are the aberrations. Okay, let me tell you one thing, these are not the true aberrations. Okay, these are not ocular aberrations, these are aberrations only which are arising from the anterior corneal surface, and these are not truly measured, but these are measured on basis of complex algorithms which do complex calculations from the Placido discs, and then it gives you the value of the wavefront. Again, it is in microns, and it is again follows the same kind of a scale. If there is a more a positive aberration, it gives you on the red side or on the warm side. If there are less positive or on the negative side, it gives you cool values. Now, if you can see over here, there is an auto scale which is used, and each color shade signifies 0.2 microns. Okay, the microns are always measured in the aberrations are always measured in microns, because the aberrations or the differences between the ideal and the aberrated image is so small that they have to be measured in microns. Okay, so it can give you presentation in a map form, or else it can give you a presentation in Zernike table as well. Zernike table basically tells you the name of the aberrations as well, right? And in this, lower order as well as the higher order aberrations are shown, and it is not affected by accommodation. Okay, because it measures only the anterior surface of the cornea. Accommodation will be affected only and only if you are using a true aberrometer, okay, which measures the total aberrations of the eyes. Okay, so now if you can see over here, this is Zernike polynomials. So it tells you that what kind of aberrations are there, and how much is the intensity of each of the aberrations. Now we have to remember one thing: the aberrations which are shown over here, uh, they do not have the effect of diffraction in it, right? So the image quality is basically affected by diffraction as well. So this shows you diffraction limited aberrations. Okay, we won't be going too much of in too much of details about it, but one thing we need to remember about the vertical comma. Okay, so whenever you see high values of vertical comma of minus 0. More than minus 0.16 vertical comma, it means you have to start suspecting of some kind of an actitic disorder, especially keratoconus. Right, so this is how it presents. These are the aberration maps. We don't see such typical maps because the aberration maps, what we see are a combination of all the aberrations which are present. But you can mask out the aberrations when, if you want to just look at a specific order of aberrations. But we won't, as I told you, we won't get into much of details of it. The next map, what we will see is something known as an image simulation. Now, the name only suggests that it's a simulation of how the patient is going to see because of the anterior surface of the cornea. You can have different types of images over here. You can have this chart, you can have a scenery, and so on. There are 5 to 6 options over there. So basically, this can help you in understanding objectively of how the patient is seeing, right, or due to the anterior surface of the cornea. Later words, I will be asking some of our friends on how more we can use this, but not right now, at a later stage of the lecture or at the end stage of the lecture. Moving further, there is something known as a PSF. The PSF stands for point spread function. Okay, as I told you that whenever a point object emits a rays into the eyes, we expect that a point image is formed on the retina. But because of the cornea, because of the lens, the point object does not form a point image, but instead it causes an image which is spread. Okay, so how much this point is spread, it is shown in this basic map. I would like to just ask, just please confirm, can you see the PSF slide, or you're still seeing the aberration map slide? Can you please tell me?
Yes, sir. Yes, we're seeing it, sir.
Okay,
Yes,
you can see, right? You can see the PSF map, right? Great, great, great. Okay, okay, I'll just move further. So basically it tells us that how much spreading of a point will be done by the anterior surface of this cornea. Now there is something known as an MTF. MTF stands for modulation transfer function. Okay. Now what is the modulation transfer function? Now this is basically a measurement, and it tells you that how much contrast or how much light intensity it lets pass through itself.
Okay, now suppose if a 4 candela bulb is lit outside the cornea, now in front of the eye, suppose if there is a 4 candela bulb which is lit, does it let 4 candela pass through it, or it is letting only 3 candelas pass through it due to the structure of the cornea? So this MTF basically tells you that how much is the light intensity which is being passed through the cornea, or through the specific anterior surface of the cornea. Okay, so now in this MTF, as you can see over here, the central bright spot, the more the bright, better is the MTF. Okay, now I'll tell you a little bit about the relation between the MTF and the PSF. First things first, we need to remember that the MTF and PSF are inversely proportional to each other. Okay, so as you can see over here, the first one, the first image, as you can see, this is a PSF. Okay, so the PSF is thin. That means this point image is not spread too much, or it is not spread at all. So as you can see over here, MTF is very well distributed. That means there is a lot of light intensity which is being passed through this specific cornea. Now let's look at the second example that is in the center. Okay, as you can see over here, there is a distribution of the PSF. Okay, it is not as thin as the previous one. There is a distribution which is observed over here. That means there is a more spread of the point. And if you can see on the lower side, the MTF has now shrinked. That means a less intensity of the light is passing through it. And in the last image, if you can see, there is a lot of spreading of the PSF. That is the point image which is formed. It is not point at all. It is spread to a very huge proportion. Whereas if you can see on the MTF has almost become very thin. That means the intensity of the light which is passing through it is very less. Now MTF and PSF can, objectively help you to understand that what kind of vision the patient might be having, right? So if the patient says that I'm unhappy with the vision, the patient says that, yeah, my vision is the patient's vision is 6, still the patient is unhappy. So you can understand over here that, yeah, the contrast has lost. Just because the patient is reading 6, that does not mean he is having perfect vision, right? But let me tell you that this is only of the anterior surface of the cornea and not of the full optical system of the eye. Let's move further. Now there is something known as a Pathfinder. Now this Pathfinder is a very smart assistant. Okay, so what this does is, as I told you that there are 12 things which are measured by the mean curvature map. So these 12 values, okay, these 12 values, the 9 values, basically not all the 12 values, but 9 values. Which 9 values? I'll just tell you that. So the 9 values are used in order to generate a map like this. In order to generate a map like this, as you can see on the left. So there are 5 things which are mentioned. There is something known as a normal. There is KCN pattern. There is myopic LVC, hyperopic LVC, and other. Now let me tell you, the Pathfinder software has got normative data. First things first, of the normal cases. It has got data of known cases of keratoconus, subclinical cases of keratoconus, cases of PMD, PMCD, and then it has got topography reports of mean curvature. Let me tell you, it is the mean curvature. The mean curvature reports of myopic LVC. Myopic LVC means the patients who have undergone laser vision correction, or the LASIK or LASIK or PRK, and who had preoperatively who had myopia, and they have got data of hyperopic LVC as well. Those who had hyperopia and they got rid of it by LASIK or LASIK and so on. And the last is the other. Other means the patients which are not classified in the above mentioned modes. Right. So what it tells you is, suppose if you capture an image of a patient, so it compares all the values with this database, and it tells us that how much it is matching with which kind of database. So suppose if you did a topography of an X patient, so in this case, in this specific case, so it says that it is matching with the normal database 76%. So there are 76% chances that this patient's cornea is normal. So basically we know that this is a normal cornea.
Okay, so let's have a look at Pathfinder 2 of normal cornea. Now, as I was telling you, that 9 things are mentioned. So the superior inferior, the superior nasal, inferior temporal, right? All those values are used in this Pathfinder map, and the other values are used over here. As I showed you in the map over there initially, in the chart over there initially, in which the values were mentioned is negative, in the red, in the yellow, and in the green side. So similar thing happens over here. As you can see that there are two red bars in each of them, right? If you can see the shape factor, this is a negative, this is a negative, and it is shown in the red, and over here as well there is a red value and there are green values. Okay, so our patient's shape factor is falling into 0.3 and it is in the green data. That means it is normal. Again, TKM is falling in the green, again it is normal. CIM, again it is falling in the green region, again it is normal. Now if you can see over here, now we can see a axial curvature map and we can see a mean curvature map. Most of the regions are falling in the green area. So that means it is more of a normal case. Now again, you have to look at the type of the scale which is being used and you have to correlate it with your findings. These are the 9 values over here which are utilized in your Pathfinder. Okay, so in a nutshell, 9 values are used in the Pathfinder for to get you the percentage for matching, and these 3 values tells you that how much normal or abnormal the cornea is. The resultant of all these things you have to use and you have to come to a diagnosis based on this. But we have to remember one thing: Pathfinder can be deceptive at times. Okay, it can give you false positive readings as well. What do I mean by false positive? The patient may not have keratoconus, but it is showing as a keratoconus pattern. But we'll come to that at a later stage about how it appears. Now let's have a look at pattern of with the rule. Can we have someone from the crowd to help us read this read this specific axial curvature map? Anyone? Let's start from the this color map, and then you can tell what kind of a dumbbell is this, and so on. Anyone? Okay, so I think I'll have to read it out. Okay, on the left side you can see that the palette scale, they are using a standard. Yes, yes. I
I
think
was
we
saying,
have someone.
can I try? I said.
Oh yes, definitely, for sure you can try. Very good.
Based upon the color coding of the axial curvature, it shows bow tie pattern, which implies there's a with the rule astigmatism based upon the
Okay,
color
very good.
coding.
Okay, okay. And why do you say it's a with the rule?
Because the vertical meridian is in warmer color, which suggests us having a steeper side
Very good, very good.
within a 6 mm of area. So
Okay, perfect.
it suggests with the rule astigmatism.
Yes, it's a with the rule astigmatism. So as he mentioned that it's a with the rule and it's a symmetric bow tie, right? And the type of the scale what is being used is a standard scale with a half diopter change with a half diopter per shade. And one more thing I want to tell you why it is with the rule. So that is because we see a vertical steep area. So in with the rule, when you prescribe the glasses in minus cylinder form, your axis meridian will be at 180 degrees. So when you write a prescription, you will write the axis as 180 degrees. Now let's go to the next slide. So this is against the rule, a simple photograph of against the rule. Unfortunately, I couldn't get the actual photo because of the lockdown. I couldn't get it from the hospital. So whenever you see a horizontal bow tie, it is a significance of against the rule. Can someone please tell me where is the steep region, where is the steep meridian in this specific topography map? Anyone, based on the color coding, can someone please say?
So horizontally, sir. So horizontally more stable.
Sorry.
It is horizontally more steeper, sir.
Yeah. Horizontally it is steep. Yeah, perfect. So, which one will be your axis meridian? Okay, so basically 90 degrees.
For minus,
yes,
sir. For minus cylinder, it is for minus cylinder, sir, it is
vertical.
Horizontal. Yes.
Vertical. It will go towards the 90 side. So the numbers are not clear over here. It is somewhere around 95 degrees or something like that. Right. So whenever suppose if you perform a refraction of a patient with very low cylinders or with extremely high cylinders, so sometimes you may get confused. The patient may get confused with the astigmatic fan or as well as with JCC. So at this period of time, you can really take help of corneal topography. It can really tell you about the axis of the cylinder. Right, so we'll go to the next slide. This is oblique astigmatism. This is nothing but a symmetrical bow tie, but which is not present horizontally or vertically, but it is present obliquely. Okay, there is not there is no rocket science in this. Right, so whenever you see a pattern which is not vertical or horizontal, you state it as an oblique astigmatism. Next is, when do we suspect for keratoconus? First things first, when we see irregular rings, whenever we see the steepest keratometry is more than 47.2, please remember this thing very nicely, that 47.2 steepest region on the cornea, it has to be suspected for keratoconus. The superior inferior difference, as I told you, should be if it's more than 1.5 diopters, please start suspecting. Skewing of axis, as I told you initially, more than 22 degrees, start suspecting. Apex displacement inferiorly. So as I told you, apex, what is apex? Apex is the steepest part, which is signified by the triangle. So if you see that there is a too much of inferior displacement of the apex, then you start suspecting. And one more thing is Q value of more than -1. Can someone please tell me that if I'm telling you that we should suspect that there is a Q value of more than -1, then what will be the shape factor? If you want to suspect the patient based on the shape factor, above what value you will start suspecting? Can someone please put a comment on it? It's a very simple answer. Yes, someone?
Symmetrical or asymmetrical acute radial axis, something like that.
Sorry.
Yeah, it will be a prolet shape.
Okay, very good, very good. It's a prolet shape. And suppose Q value is -1. So what will be the shape factor value? Can someone please say? Shape factor is exactly opposite of Q value. So suppose if the Q value is -1, so the shape factor will be +1. Okay, we need to remember this always. It's exactly opposite. Right. I hope everyone is following this. And the next is high eccentricity value. Again, I mentioned in the keratometry map slide that eccentricity is nothing but the speed at which there is a flattening of the cornea from that specific region. So whenever you see high eccentricity value, that means the cornea is getting flatter all of a sudden. Okay. And the last one is CCT, which is less than 470 microns, but we cannot measure this on topographer. But you have to be smart enough to correlate all these signs together. So presence of just irregular rings, or presence of just skewing of axis, or presence of just high eccentricity value, or presence of just superior inferior difference is not enough. So there should be at least 2 to 3. Generally, there are 3 criteria which should fulfill in order for you to suspect it as keratoconus. But remember one thing: maybe most of
these signs may be absent and the patient still may be having keratoconus, that is because the keratoconus starts from the posterior surface of the cornea. Am I audible? Sorry, I got a call. So yes, so so you have to remember that that you have to remember that most of the signs may be absent and still the patient may be having keratoconus because the keratoconus starts from the posterior surface of the cornea, right? So in such cases you have to put the patient on pentacam or any kind of a corneal tomographer. Now can someone please tell me what could be an early sign of keratoconus? Suppose if you don't have a keratometer, suppose if you don't have a topographer, suppose if you don't have a pentacam, but you want to suspect this, but when will you suspect this? Still, when will you suspect this case as a keratoconus suspect? Can someone please shed some light on it?
Sir, on scissor reflection, on radioscopy.
Yes, perfect, perfect. This is a golden answer. Very good. Heads up. So this is a gold standard answer what he gave. Caesar reflex on the retinoscopy. And one more. Can you please give two more signs? There will be two more signs along with this, along with the Caesar reflex.
Bogus twice, I sir.
Monsoon side.
No Munson signs. I'm telling you that the patient is
Sir,
subclinical. Is at a subclinical stage of the keratoconus. It's not at a clinical case. It's not a clinical case.
sir,
It is at a
monocular diplopia,
sorry.
monocular diplopia, uniocular diplopia.
Monocular. Yeah, yeah, perfect, perfect. Yes. One more thing.
Prominent corneal nerves.
No, not really. You can. Okay, the patient's vision will not improve till 6/6. And one
Yes,
more
sir.
thing is that the patient will present with increment in myopia as well as in astigmatism. So you will come across a case who says that, sir, my astigmatism was half a diopter last year, but it is one diopter this year, and the patient's age is 23. Now we know at the age of 23 we don't expect changes in the astigmatism. So then why? He may even say that, yeah, 5 years before I did not have glasses as well. So this kind of a history we understand. Okay, this could be a keratoconus. This could be a subclinical stage of keratoconus, which is right now may not appear on the corneal topographer, but it can appear on your retinoscopy during your vision while taking the history of the patient, a family history, as well as it might appear on pentacam. That is the corneal tomography or OpScan and so on. Right. I hope everyone is following about when to suspect a keratoconus. Right. So suppose if any of you is owning an optical showroom, or if you have an optometric clinic, and if you don't have access to topographer, it does not mean that you cannot diagnose a keratoconus. You can definitely diagnose. You have got a very beautiful tool known as a retinoscope. Right. So that's how it is. Let's go ahead. So this is a clinical case of keratoconus. So let's look at the rings images. As you can see, the rings over here, they are very close to each other in this region. And you see this is an asymmetric bow tie. There is a skewing of axis, right? So let's see. Let's measure how much is the skewing. Let's do it on the axial map, right? Because on tangential you are not able to see the superior oval. Let's look at the axial curvature. So suppose if we draw an imaginary line, so this is 90 degrees over here, it is reaching the 90 degrees. And the second one over here, if I draw a line, then it is reaching 130 degrees. So the difference between the 90 degrees and the 30 degrees is how much? It is approximately 40 degrees. So there is a skewing of axis of 40 degrees. Right, so this is a confirmed case of keratoconus. I mean, definitely we know based on the keratoconus pattern on the Pathfinder 2, we can see the same thing on the tangential curvature. Right, the steepest area in the central 3 millimeter is 46.60. But if you look over here, this is matching with almost the white region, and the white region is standing for 52 diopters. Right. So a lot of signs are fulfilling the keratoconus criteria. Hence, we can say that this is a case of
keratoconus. Right, let's go on to the next one. Yes, so as I was telling you, I have a difference between the PMD and keratoconus. So we know that the keratoconus starts from the paracentral, central, or inferior peripheral region, right? And there is a thinning which is observed in the central region as well. However, in PMD we don't see much of central thinning, or maybe no central thinning at all, right? And secondly, what you need to do, what we need to see is in keratoconus, when you see steepening in the inferior region, it is not in the peripheral region, but it is in the mid peripheral region. You will see most of the keratoconic changes in 3 to 6 millimeters. Whereas on the other hand, in PMD, you will see there is a huge area which is affected, huge area of steepening, which can vary from 4 o'clock to 8 o'clock region. Okay, and it will give you an against the rule astigmatism. Whereas on the other hand, keratoconus, which is on the inferior side, will not give you against the rule keratoconus, but against the rule astigmatism, but it will give you oblique astigmatism. Right, so these are the few things that we can use to differentiate between the two conditions. And PMD, we see something known as a kissing dove pattern. So if you can see, these are the two birds or two doves which are kissing each other. Over here, you see that there is a circle. Right, so that's how it is. Again, the keratoconus has got a lot of shapes, but I have not added all the shapes in the slides. But yes, you will come across a lot of different shapes of keratoconus as well. Now this is again a case of clinically diagnosed keratoconus. Can someone please come ahead and try to read this report, if anyone would like to? Anyone? All right, so let me just do it by myself. So in axial curvature map, if you see there is an inferior steepening, right? Asymmetrical bow tie, inferior steepening. The steepest area is matching with approximately 58 diopters. In the mean curvature as well, you can see there is an inferior steepening as well. And you can see the maximum mean curvature is in red. The mean inferior superior, the mean inferior nasal, superior temporal, the mean inferior temporal, superior nasal are in red regions. Right, even over here, if you can see, CIM is present in the red region, TKM is in red region because it is 51 diopters, and shape factor is also 0.8. Now, if you look at the shape factor, this is almost abnormal. This is not fully abnormal, but it is almost abnormal because it is in the yellow region. But that does not mean that this is not a case of keratoconus, because other signs are getting fulfilled. And if you can see, keratoconus pattern product probability is 84%. Now, is this truly a keratoconus suspect? Can we really say that this is a keratoconus suspect, or this is a known case of keratoconus? You cannot really call it a keratoconus suspect because this is termed as a keratoconus suspect. But I would not say that this is a keratoconus suspect. I would say that this is a case of a keratoconus because remember one thing, it starts from the posterior surface of the cornea and not the anterior surface of the cornea. So if these many changes you observe in anterior surface topography, that means when you do the tomography, you will see more signs of the keratoconus. Right. Let's go on. Now this is a case of myopic LVC. So as you can see over here, in the center region, it is a flat area. And if you even in the mean curvature, we see there is a central flat area, and even the Pathfinder is showing that it is a myopic LVC. I really need an answer from the crowd that what other condition, what other procedure can give a similar appearance of myopic LVC? Similar appearance like myopic LVC. Someone please, I think contact lens specialist may be able to answer this question. Anyone? Okay, we can see similar kind of a pattern in patients who are using ortho-K lenses, because in ortho-K lenses there is a central flattening which is done, Right. So the Pathfinder may show that there is a myopic LVC, but the patient may be using the ortho-K lens, and hence it is causing a central flattening. So suppose if you are ortho-K practitioner, if you want to be an ortho-K practitioner, you should be aware of these kind of patterns. So this is what you basically target on ortho-K. This is something known as a difference map. We are almost done here. Just a couple of more slides. So this is a pre-operative and this is a post-operative tangential curvature maps. And this basically tells you that what is the difference between the pre-op and post-op. Okay, again it uses the same kind of a scale. Any warm colors will tell you that it is steepened, the area is steepened as compared to before. Any blue regions or any cool colors will tell you that the area has flattened. Next is again, this is another case of myopic LVC. But if you can see over here, this flat region is pretty much displaced. Okay, so could this be a mistake in performing the surgery by the patient when the patient moved the fixation, or this could be a high angle kappa as well. So that's why deliberately decentered treatment has been done. Right, so you should be very vigilant while you are performing this thing. Now this thing, please, someone, I really need a volunteer to say what pattern could this be of. Anyone, please. The steep K in this, it is showing 48.96 or somewhere around that, and the flat K is somewhere around 46. So can someone please say what could be a probable case? What could be this case probably? Just drop in your differential diagnosis, please. Anyone?
It does not seem like a thinning of the cornea, but
Okay.
it's rather than seems more thicker cornea.
No, this is not thick or thin, right? Because we don't check the thickness in this. So what does the pattern look like? If I answer, everyone will be thinking that, oh
It's
my
more
God,
or
I
less
knew this.
showing like a round,
Uh-huh.
more or less showing like a
Showing like,
round or oval pattern, round or overlap
okay,
pattern. Like
okay,
axial map showing round pattern.
okay, but it's not a round pattern. So let me tell you. Now please look at the chart very critically. Now this area is a steep area and this is a flatter region, right? So in what kind of cases do we see such appearance? That is in hyperopic LVC. So when a LASIK for hyperopia is done, the central region is kept the way it is and the laser is applied in the mid-periphery region. So the mid-peripheral region becomes flat and the central stays steep. Right, as you can see over here, mid-periphery is flat, central is steep. So this will be a hyperprolate cornea. Right, so hence it is a hyperopic LVC. Right, so next is this is just a case with post-keratoplasty in which you don't see which you don't see patterns which are not similar to myopic LVC, hyperopic LVC, keratoconus, and so on. So it will generally show as others. Right, nothing much you can do about the CIM or TKM or shape factor in this because this is an implanted cornea. So not really you can do much. But yeah, if the sutures have to be removed, then these value might change, and you might get an idea if the patient's vision is improving or not. Right, this is. Can someone tell me that is this keratoconus? This is the last slide for the day. Please, someone can comment if this is a case of keratoconus. Is this fulfilling any criteria for keratoconus? What is your take on this?
It, it doesn't seems like a keratoconus as the steepest key meridian is close to 45.
Okay.
But the first criteria has to be more than 45. So in that criteria may or may not be, but we can keep it as a suspicious.
Okay, you will suspect. Okay, but why would you? Why would you suspect the case as keratoconus? I mean, what is the reason?
Because first reason is steepest K is above 45. That is one criteria it is meeting here.
Okay, but our criteria is
Just
for
one
more
point.
than 47.2. Yes, yes. Now it will. The slide has come now. Please, all of you, take your time and look at it. Does anyone else support that this is a keratoconus? Does anyone else supports the Pathfinder that this is a keratoconus pattern? Do you agree with the Pathfinder in this? Basically, and yes, so this is all about keratoconus. This is all about the corneal topographer. I would like to thank Meroi for having me here. Thank you, Kapil, and thanks to the whole team for having me here. If we have any queries, we can take up the queries, and then we can conclude this session.
Yes, sir. We had already a question, but after restarting it, it was like disappeared. I guess there is one question I'm going to read out for you. So I'm asking
Yes.
for, is there any relation between the corneal topography and aberrometry?
If you ask me about the relation, yes, there could be a relation because the steep, if there is a general, if there is a local steepening at any regions of the cornea, then yes, definitely you will see changes in the aberrometry. So right, so as I told you previously that you have to keep an eye on the the vertical comma. So yes, there is a relation between the two, not a relation between the two machines, but yes, there is a relation between the readings and the outcomes of both of them.
Actually, sir, one of my friends was done research on the aberrometry based on the VKC that induced by the VKC inducing the keratoconus and measurement of
Okay.
aberrometry.
Okay.
So the spherical aberration was the most commonest in the. It's not showing any type of specific aberration, but it was mostly shown the spherical aberration.
Yeah, spherical aberration will definitely see, but in cases of, if you talk about keratoconus, we see more of a vertical comma. Because when does the comma occur? Comma occurs when there is a misalignment of the optical structures. Okay, so in keratoconus, what's happening is there is an inferior steepening, right? So the light is
Yes.
more refracted by the inferior area of the cornea. Now this, this more refraction which is occurring at the inferior region does not pass through the center of the lens of the crystalline lens. Right, so there are two images or more than two images which are being formed. There is one image which is being formed in the inferior region, and there is one image which is being formed in the central region. You understand? So there will be 2 to 3 images which is formed and which will give a shape like a comet, and hence it will cause a comma. You understand? So in cases of keratoconus specifically, if we talk, yes, we can see comma. But if we see a nipple-shaped keratoconus in which we see central keratoconus, there will be more of a spherical aberration. I hope this was clear about regarding your query.
Yes, sir. So,
Yeah.
Nielsen, sir, if you want to ask the question, you can unmute. Yes, sir. Go ahead.
Yeah. Thank you so much for the such a elaborated talk, sir. It was very nice ending the session. I was wondering, like, it is proven in the many literature that in Asian population and in European, or based on the ethnicity, there is a variation in the corneal toricity. So when all these machine uses all the database from the other ethnicity other than Asian, and still we are taking that as a database to say the result of what we are getting in our place, and then again
Hmm.
using their formula for their database. Has there
Okay.
any new development has happened where we can use our own database, or is there any progress happened in that field? Am I clear?
Uh,
Am I understandable what my
yeah, yeah,
question?
I understood what you're saying.
Yeah.
Yes, yes, I understood your question. So if you ask me personally, so I have not come across any such kind of a new database which is specifically for our ethnicity. There is the Asians or Southeast Asians. So I'm really not sure. And generally we are going ahead with the European or the Western databases right now, because and again. Uh, the rules and regulations of each and every countries are different, right? So I'm
Yeah.
not sure if the companies can perform such multi-centric database collection researches in our countries, let's say namely in India or Pakistan, or maybe in Nepal or Indonesia or Singapore. So I'm not sure about how they will go about that, but yeah, currently we are just using what is kept in the machine, and
The
and
reason.
and they are not. Mhm. Mhm.
Sorry for the disturbance. The reason
Yeah, please.
why I was asking this because in many years in India and in even in Asian countries there has been attempt taken for the normative database for the retinal finding what we use in the OCT where we have a same principle where we compare with the
That is
normative
true.
database. So that is being taken in the multi-center and it is now in a pipeline where they will be using for the clinical purpose as well. So I was wondering whether it is happened for the topography as well or not.
Yeah, I'm if something is going on, then I may not be aware of it. But currently, I'm not aware of it. To be straightforward with you. But
Okay.
yeah, I'm not aware of it. If anything is going on.
Okay. No issues, sir. Thank you.
Yeah, yeah. Thank you. Yeah. Do we have any other queries?
Sir?
Yes.
Yes, sir. So there is a question from the Amit Kumar Singh. So
Yeah.
his question is when cycloplegic refraction is required in the case of myopia or other before the
Hmm.
refractive surgery for the aberrometry finding, please
Hmm.
light on it, sir.
Okay. 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 I'll just read the question. Just one moment.
Yes.
Uh, yes. From if you tell me from aberrometric findings, if you see aberrometry, okay. So if you're using the true aberrometry machine, and if you find that there are changes in acceptance, okay, subjective acceptance, and the refraction what you find in the aberrometry machine, yes, you need to do a cycloplegic refraction, because if you see the differences between the two, that means the accommodation is active of the patient, and you might get falsely high myopic reading or falsely high myopic refraction. So yes, you need a cycloplegic refraction, and definitely in all the cases you need to do a cycloplegic refraction in myopia. Buddy. I hope
Okay.
this is clear, because that's what I understood from the question.
Yes, and it was the question. So if anybody have the question, please unmute your mic and you can ask the question.
I think we have a question from Wrinkle. The question is, could you please once again describe the last slide? Can you please? Okay, the last slide. The collateral uses. Is this what you're talking about, Wrinkle? Please
No,
confirm.
sir, no. That one slide with that equation value shows wrong due to tear instability or something
Oh
you're
yes,
talking about. I
yeah,
was
yeah. This
offended.
one. Yeah. See, basically, it's not a case of keratoconus. This is just a case in which the
Okay.
tear film of the patient while performing the topography was not proper. So that's why it is giving you a false reading of false probability of keratoconus pattern. So so you have to keep in mind while performing topography that the tear film of the patient should be stable. Yeah, Kapil, do we have any other queries?
I guess we almost completed all the question. So
All
I'm
right.
just dropping the
Great.
yes. Yes, okay. So thank you so much, sir, for such a wonderful presentation. And I guess we have answered many of the queries and considering the time limits. Okay, here we go. Okay, so here I announce the discussion, announce the closure of discussion session. Before ending the today's session, I would like to again express my sincere gratitude towards the presenter, sir, and all the attendees. And also, I would like to appreciate all the helping hands for iTalks program. Herewith, I am ending the Tuesday session, requesting all of you to drop your feedback and review, which was I recently dropped your file in our messenger group. Sir, once I leave this meeting, I'll be adding on this group, and if you have any discussion, and we can continue the discussion.
Yes. Feel free to
Okay.
ask any questions. Yes.
Yes, sir. So we have one messenger group used to discuss a lot of questions. So I'm
Yes.
going to add you after ending the meeting, so we can discuss, continue with the messenger as well. So herewith,
Yeah.
I'm ending the registration, requesting all of you again. Please drop your review and feedback. Stay safe. Keep in touch. Thank you so much. Thank you so much, sir.
Thank you. Thank you. Thank you. Have a good day, everyone. Stay safe. Have a good day. Thank you.